Hi everyone, my name is Shannon Tinkler and I am the lead clinical consultant here at Synapse Care Solutions, and I'm here to talk to you today about how to start a cooling program for your hospital. I'm going to outline all the critical elements you'll need to begin using this neuroprotective therapy, from nursing education to equipment purchase and EHR integration. So enjoy, and please email me if you have any questions. It's shannon@synapsecare.com. Thank you.
Okay, everyone, let's get started on how to create a cooling program. So here's a list of things that you're going to need. We'll go over all of these things in detail. Just a general idea of everything you need at your institution to get started with a cooling program. So you need eligibility criteria, which infants are we going to cool. We need a device to cool those infants. We need some neuromonitoring equipment and some neuroimaging capability. Medical staff and nursing staff education is going to be a big part of beginning your cooling program. The availability of ancillary staff, so OT, PT, speech language pathology, and lactation consulting, all a vital part of having cooling at your institution. And EHR integration, and then as well as long-term follow-up. All these babies need access to long-term follow-up, so it's important that we can provide that service as well. So why does your institution need a cooling program? Therapeutic hypothermia is the only treatment for hypoxic ischemic encephalopathy for the term newborn. And initially, the institutions that did cooling were the ones who were involved in trial. But since those results have been published, many institutions have started their cooling programs to really expand our access for all of these babies who have hypoxic ischemic encephalopathy to get this treatment. You know, we have a short time period where we can begin this treatment, so it's important that we have cooling centers within a radius that's reasonable to get to these babies. More and more hospitals across the nation are really looking to become a cooling center to increase access to this neuroprotective treatment. There's 3,000 hospitals across the United States, and only 1,000 of them have NICUs, and even a smaller percentage of those have cooling programs. So think about those odds, and well, depending on what study you look at, neonatal encephalopathy or HIE happens anywhere from 1 to 8 times per 1,000 births. So it's a fair number of kids who need this treatment, and having a cooling program in your institution will increase access so that everybody can really have the availability of this treatment. It does require a lot of working parts, so it's multidisciplinary. You need sessional monitoring and imaging and access to follow-up programs and ancillary staff. So yeah, there's a lot of working pieces, and we'll go over all of that. So eligibility criteria. So your medical staff needs to sit down before you start your cooling program and decide which infants they're going to cool. Infants with HIE are in the original trials have been qualified to cool using kind of they need a two-pronged qualification. So they need to meet biochemical and neurologic exam criteria to qualify. The biochemical criteria is a core gas or a first gas of the baby within an hour that has severe metabolic acidosis. And the neurologic exam criteria uses the Sarnot exam to stage an infant's level of encephalopathy. So it's a pretty standard exam. This was published back in the 70s that kind of gauges, based on the infant signs, how severe their encephalopathy is. Here is an example of your modified Sarnot exam. So for infants to qualify for cooling, they need to have at least moderate encephalopathy. So they don't have to have yes to every category in moderate, but a fair number of them. Again, that's based on your medical staff, what they're going to qualify as encephalopathic. So, and it's important that it's consistent and that your medical staff is well versed in doing this exam. So they might need someone to come in and kind of go over this exam with them before they start. Next, you're going to need a cooling device. So once you've established that criteria, you're going to pick what kind of cooling you're going to do. There are servo-regulated cooling devices. You have whole body versus selective head cooling. The selective head cooling device, the cool cap, which was used in a few of the original trials, is no longer available for purchase in the United States. However, it's still used in many institutions, and it's used internationally. So it's validated, it's effective. It's selective head cooling with a servo-controlled cap, and then you have some mild systemic hypothermia to go along with that. With whole body cooling, you cool a whole body, the core temperature, down to your target range. So not just the head, but the whole body gets cooled. These devices, some of them are the Blanketrol, the Ticotherm, the Criticool, the Arctic Sun. They all control that with a temp probe, kind of how you would your regular isolette, but the baby's on a blanket getting usually some cool water or gel circulating around. Low technology ways, there are low technology ways to cool babies as well. Ice packs, there's servo-controlled fans, cooling the environment. So that is something that happens, across the world. Many of the institutions in the United States passively cool, so we'll turn off the radiant warmer while we're waiting for pickup by a transport team and monitor that core temperature really closely. We want to make sure it doesn't get too low. So neuromonitoring is a huge piece of the puzzle for a cooling program. Infants who have neonatal encephalopathy or HIE are really high risk for seizures. As many as 40% have seizures at some point during hypothermia treatment. Most common to have those seizures in the first 30 hours, and then occasionally during rewarming as well. The thing with seizures is that in neonates, up to 80% of them can be subclinical, meaning they have no outward signs that they're seizing. So there's no lip smacking, no arm jerking, no tongue thrusting, not an outward sign, and these babies are having a seizure. They're visible electrographically. So it's important to have a neuromonitoring capability. We think that seizures cause more injury to the brain, so you have an injured brain of a baby who's got HIE, and then they're having seizures, which could be putting more injury into that brain. So it's important that we have the ability to recognize these seizures. At minimum, they at least need AEG, amplitude integrated EEG, through the duration of cooling and throughout rewarming. AEG does have its limitations though, so continuous video EEG is really the gold standard for monitoring during therapeutic hypothermia. Ideally, you'd have continuous video EEG on the entire time the infant is getting treatment and throughout rewarming, just because there is a higher risk of seizures during rewarming as well. But we can have the best of both worlds. A lot of the full Montage EEG devices, so the full continuous video EEG, they also offer the ability to view AEG, the trend, while the study is in progress. So nurses and the clinicians at the bedside get to see the trend that they're used to seeing, and the neurophysiologist, the EEG reader, is down in the lab and is able to view the full Montage EEG. And this is important because the ACNS, the American Clinical Neurophysiology Society, says that their guidelines state that full Montage EEG should be fully reviewed at least twice a day. But there are so many gaps in between that, and us at the bedside are the ones really keeping the closest eye on this baby. So having the trend available is really, really valuable, as it really allows the bedside clinicians, nurses, doctors, NPs, PAs to view and check for seizure activity, and to maybe alert the electrophysiologist to any signs or spots where they think they might have seen something suspicious. It's kind of the best of both worlds there. If it's not available at your center for continuous throughout the entire time of rewarming, if you have a 24-hour EEG for the first 24 hours during cooling, and then again, monitoring with AEG would work as well. This is an example of a machine that does full Montage EEG in the background, but has the AEG trend up for the clinicians at the bedside to use. So we get to see our left, right, and cross-cerebral views, and then same on the bottom, we get to see our raw EEG feed. This infant's actually having a seizure right there. But yeah, so we get the full benefit of having the full Montage EEG, and then easy for us at the bedside to see what's going on with this baby. The other piece of neuromonitoring equipment you might want to purchase is NearInfrared Spectroscopy. It's kind of a new technology that's giving us some insight into brain perfusion. So it monitors a regional mixed venous arterial saturation, gives us an idea of oxygen extraction, if that oxygen is getting pulled out of the blood and into the tissues. So that's another piece of equipment that you might think about purchasing. High cerebral saturations, greater than 90% in the first 24 hours of life, are associated with poor neurodevelopmental outcomes. So it just gives us another piece to the picture. It's easy to apply and maintain the sensor. It's non-invasive, so it's not going to hurt the baby. It's just a sensor on their forehead. We can also monitor renal and mesenteric saturations as well with the same sensor. So it's there, it's available, it's very easy to use. Let's talk about neuroimaging. So babies with HIE, we all want to know their outcome or what happened to them. And MRI is really the gold standard image for evaluating the extent of injury following hypoxic ischemic insult. And that's, the different pictures that we can get with MRI really give us valuable insight into the extent of the injury and the timing of the injury. So depending on what you want to look at in terms of the brain, it's really the time of the study is important. So if you want to look at the initial injury, when did the injury occur? You want your MRI to be within the first 24 to 96 hours of life. If you more want to look at how this baby's going to do in the long term, your best image 7 to 10 days after birth. So because of this, some centers do get 2 MRIs. Not everybody has this capability. It's expensive. It requires a lot of time, some special positioning, and occasionally sedation. So not everybody has this capability to have 2 MRIs. Some institutions kind of shoot for the middle after cooling is done, but before the 10 days is on, so we can get a little bit of insight into the initial injury and maybe some help with prognostication as well. So that will be part of your study protocol that your medical team decides, like when are they going to get that MRI. A lot of centers also do cranial ultrasounds. It's useful to see if the baby has an interventricular hemorrhage, probably at the beginning of cooling when there is some coagulopathy. So we just kind of know if this injury happened before we started cooling, or if it gets bigger while we're cooling. It can occasionally also give some insight as to the extent of the cerebral injury, but MRI is really the thing that we're going to go to give us the best picture of what this brain looks like and how damaged it is, or if cooling was able to help with that. So your medical staff is going to need some education. Principles and pathophysiology behind hypothermia is an important thing to teach them. Why this works, what babies are going to be cooled, how to identify them, who is at high risk for these things. That's all going to be part of your education for your medical staff. Common risks, side effects, and physiologic support needed during treatment. So what do we see normally with hypothermia? What are the things you can expect? What are the things to look for, kind of anticipate, and things like that? Other common organ involvement and injury, the brain isn't the only thing that's been injured. So making sure that your medical staff is prepared for the other, kidney and liver involvement that can happen with babies with HIE. Common laboratory and radiological evaluations during cooling, training on the different modes of operation in the cooling device. This is important because really your medical staff is who your nursing staff is going to call to say, hey, my baby's getting warmer, I can't get the machine to work, can you come help me? It's important that they understand the basics of this machine as well, and maybe some higher functions. If you're using EEG or have the EEG trend available, so interpretation on that is going to be a big part of training as well, so that they know kind of what's going on with this baby's brain. Ongoing training and updates on the results of clinical trials and adjunct therapies. Important piece as well, cooling, there's a ton of trials going on right now of things that we can do in addition to hypothermia, since we know hypothermia is effective. So what else can we add on to help this baby's brains as they get older? Or what other therapies we could put in there to kind of make our hypothermia work even better? So there's lots of clinical trials going on, trialing what's the earliest baby we can cool? How young are they? Is it safe for preemies? So can we cool babies who are older than 6 hours old? So there's all kinds of trials going on right now. So it's important that we stay on top of the latest research so that our protocols fit really what's going on in reality. Nursing education is going to be a big part of your cooling program as well and starting it up. A small percentage of these infants qualify for therapeutic hypothermia. So depending on how many births you have in your institution, and if you're a transfer center, if you get transports or referrals, kind of gives you an idea of how many babies you're going to be able to cool or you're going to cool a year. But it may be less than 10. So it's important that your nursing staff is well-versed in all of the aspects of cooling, since it doesn't happen very often and not everybody may be able to participate in taking care of a cooling infant every year. It is considered a standard practice, but it's not a regular occurrence in many, even large NICUs. So again, important that your nursing staff has practice with it and that has some clear guidelines. Again, your nursing staff is going to need education on adjunctive therapies, ongoing results of clinical trials, and all of that. So that should be a part of your ongoing education once your cooling program is in place. I think for nursing staff, it's really important to have a very specific protocol or guideline or checklist for induction, maintenance, and rewarming of cooling. It's a very stressful time, especially induction. Babies are usually pretty sick or they've been through a full resuscitation in the delivery room or coming through transport. It's very busy. There needs to be lines secured, access gotten, all kinds of lines hung. So it's a very, very busy time for the bedside nurse. So if we have these specific protocols and guidelines, it just kind of brings everybody's anxiety level down a little bit if they have something to kind of rely on and look at. That's very clear on how to start cooling, how to work the machine, all of that stuff. I think your initial education needs to include the understanding of the pathophysiology of hypoxic ischemic injury and why therapeutic hypothermia is an effective treatment. And then going over the cooling device, getting hands on that device is an invaluable tool because really muscle memory is everything, especially when you're doing something infrequently. Lab studies, there's a ton of labs that we do throughout cooling, especially at the beginning. We like to get a lot of laboratory studies. So just letting the nurses know what to expect. You can also put that in your checklist or protocol. That's helpful as well. So kind of give them an idea of what to anticipate for. And then what we need throughout cooling as well. Sedation that we're going to need during cooling are common things that are used. Side effects, physiologic responses, common meds, blood products, everything that we see in cooling kids, it's great for the nurse to be able to see this out in your guideline or protocol so they have an idea of what to expect. The risks associated with hypothermia, we make sure our nurses know that our babies are, probably going to have some good bradycardia going on, and it's going to maintain throughout cooling until we get rewarmed. So knowing that they can expect that, and looking out for hypotension, things like that it's important that the nurses get that education as well. The nurses need to really understand the different modes and troubleshooting techniques of the cooling device so that they are the ones at the bedside and they're going to be troubleshooting if your baby's going in and out of therapeutic range. They're going to be the ones troubleshooting this device. So it's important that they have an understanding of what the different modes do, if babies require a different mode and how to get to those modes. Again, a troubleshooting guide or putting this on your checklist is a valuable tool. And then if you're using EEG, it's important that they have training on the equipment, on placement and how to place it, and then of course interpretation, same as your medical staff, since they're the ones at the bedside looking at the baby 24 hours a day. Ancillary staff, so PT, OT, speech pathology, and lactation are all a very important part of the NICU life in general, and also for babies with HIE. Some babies who have suffered from HIE, they might need help with range of motion, they might have contractures, some positioning issues. They all also might need some various levels of feeding support. They might need some modified feeding techniques, assistance with breastfeeding, swallowing evaluation, just to make sure that they're safe in eating. Social work, again, I think is an invaluable tool for all of the NICU parents in general, but For parents whose babies have HIE, this is an unexpected occurrence. They're expecting to have a term or near-term baby, and coming to the NICU is not something that was ever on their radar. And they might have been through a pretty traumatic delivery, seeing their baby in a full resuscitation. So they're going to need a lot of support, and social work is a great help for that. So they also help coordinate follow-up care. They can order, durable medical equipment if we have some, feeding pumps or anything going home with a baby. Insurance authorizations, of course, also so the parents don't have to deal with that. I think is a fantastic, also part of their wonderful work that they do daily in the NICU. So I think that EHR integration is a very important part of having a cooling program. For the providers, because this doesn't happen very often, if you have a standard order set, it really decreases the stress on the providers themselves and the nursing staff, who has to then stop. They can then stop going to ask the provider for one order every 2 minutes. So if you have a standard order set, it's really, really helpful. Obviously specific to therapeutic hypothermia, so it orders the mode of cooling, the target temperature, how long we're cooling, what kind of imaging and neuromonitoring we're going to be doing, labs, blood gases. If we can order those at those prescribed intervals, again, so the nursing staff kind of has an idea of what they need to get at what time, it's a great thing. Have sedation built in there, so again, it's not something that the providers have to check off because we don't do this very often. It's more helpful if we have some kind of standardization. For nursing, it's important that they have the ability to chart all these specific things that happen with cooling. So if we have a specific flow sheet or flow rows to document on, the different temperatures of the cooling devices. So what is your water temperature? If you have a esophageal core temperature or rectal temperature, what's your core temperature? Where's the probe located? And how deep do we place it? The start and end of therapy, any EEG data that they're gathering as well. It's important for them to have a place to chart these things. So it just makes it easier if we all have our own little place to document them, and everybody then is documenting the same thing. And I think that's a really important piece of this cooling program. Makes it easier in the long term when you're going back to gather data on your statistics as well, as you can easily find these things. So access to long-term follow-up. These infants, babies who have HIE, babies who have been cooled, are at high risk for neurodevelopmental impairment, and they need close monitoring to determine if they're going to have any long-term delays or impairments. A lot of these delays don't show up in the first few months. Our babies don't do much in the first 2 months other than eat and sleep and start to do those things, but it's important that they're followed for at least 2 years so that we can really identify if they're having any of those cognitive delays. They might need follow-up appointments with other disciplines as well, depending on their needs of discharge. So if they go on seizure medication, or if they have a large insult in neurology, may want to see them. Surgery or gastroenterology if they're discharged with a G-tube. If they're having feeding issues or need help with some range of motion, OT, PT, speech language pathology would be helpful as well. So it's important that our babies have access to all of these long-term follow-up kind of appointments and disciplines. Resources for everybody. The CPQCC toolkit, if you go to this website, is a great resource to kind of talks about a lot of early screening and identification, because really, we're cooling a lot more infants because more infants are being identified. So this is a great toolkit to kind of go over the needs for therapeutic hypothermia. The ACOG task force report on neonatal encephalopathy and neurologic outcome is also a good place to look if you need some resources. Thank you very much for joining me today to talk about how to start a cooling program. Please feel free to email me if you have any other questions. Thank you.